Everyone should have an individual discussion with a radiation oncologist about this for your scenarios, but broadly speaking, historically there were studies in limited stage and extensive stage, those are the two stages we discussed, of people who half the group got radiation to the brain, half the group did not. Now it's called prophylactic cranial irradiation, prophylactic radiation to the brain, prophylactic being no evidence, no known cancer in the brain, but this kind of preventative. Preventative is not quite the right term because what it's really doing is treating microscopic disease, so something that you can't see on a scan. Now, in these historical studies, the group that got the radiation did better, lived longer. But in those trials, there was not an MRI of the brain before randomizing to which group. And nowadays, MRI brain is very standard. So more recently, there was a study in Japan that looked at individuals that had extensive stage, so metastatic stage 4. Half them got radiation and half of them got observation with every 3-month MRI brain. Now, of the group that did not get the radiation, they were more likely to later need radiation, which makes sense. Everyone in the other group got it. They were more likely to later need it, but the outcomes actually were not so different. And so this raised the question of, well, maybe those historical studies, the fact that there wasn't an MRI done, meant that there were people who, had there been MRI done, you would have seen that there was disease in the brain, and therefore it was very much therapeutic, it was very much treatment, and not prophylactic so much. And so there's a study in the US right now in limited stage and in extensive stage. And often what I'll tell patients is, hey, when you talk to the radiation oncologist, after that nuanced discussion, if you feel strongly that you want to get the radiation, you can get it. That's justified. If you feel strongly that you do not want radiation, well, that's often justified too. And if you're not sure and you say flip a coin, well then participate in the trial, because then you are assigned to one or the other. But if you have a preference, then you can choose that. And it's worth having that nuanced discussion though about anyone's specific scenario with a radiation oncologist.
Yeah, and I think this is a really important time maybe to sort of interject, or a relevant time to interject the importance of having the conversation with your healthcare providers, whether it's your medical oncologist, your radiologist, your radiation oncologist, like whoever you're having this conversation with. It's important that you educate and empower yourself to be able to have these informed conversations, right? Because you don't know what you don't know. You don't know that you should be talking to Doc X, Y, or Z about X, Y, or Z unless you know what X, Y, or Z actually are. And so I think that's an important thing that we try to do in this living room and in other program areas across GoTo is bring you this information. And when we're talking about this prophylactic sort of, cranial irradiation, that's a big decision because radiating the entire brain does not come without its own potential set of, issues.
That's right. Now, there have been some advances. The way that radiation is done now is a bit different than the way it was done before. They now spare areas of memory. Yeah. There are some drugs that can help prevent some of the side effects too. I think it's often a much scarier kind of an idea than the experience of it, meaning, we're talking about radiation to the brain just as a concept is often a scary kind of idea. But there are some real potential side effects as well, and you can't always predict exactly how that will go for everybody. And so, I often will make the analogy when talking about the side effects of chemotherapy or immunotherapy, but relevant with radiation too, is saying, if I ask you what'll happen on my drive home, not to say that a drive home is the same thing as as a cancer treatment, but just to make the analogy, what'll happen on my drive home, you'd probably say, well, you'll be fine, maybe hit some traffic. Traffic in Boston's awful. Traffic in San Francisco, I know, is awful too. So you might hit some traffic, but you'll be fine. And I'm like, well, what are all the things that can happen?
Yeah.
Now that becomes a really long, scary list of possibilities. Now, broadly speaking with radiation, again, not that it's the same thing, there are some toxicities that are more common than others, but what can happen becomes this long, scary list.
Yeah.
But you need to balance that out with what is the true benefit, and that's what we're saying is, well, there's now more study to be done to better define this.
Yeah, and I think it's a goals of care conversation, right? Not that I want to make this a whole disparities in healthcare conversation, but it's also an understanding. You mentioned what I think you're referring to as hippocampal sparing whole brain radiation, which is great, but not always an option depending upon where this treatment is being offered. So understanding that that's even a thing, to be able to have that conversation to say, hey, is this something A, that is good for me, and B, do you have the technology to make this happen, right? I don't want to scare anybody off from radiation therapy, because radiation therapy is amazing for a lot of reasons, right? Up to and including, surgery on patients who can't, otherwise have surgery or
It's often pretty anticlimactic. I mean, people go and lay on a table for 5 minutes and you don't feel anything. But this is where having that discussion with a radiation oncologist will matter. Now, I actually don't know the numbers. I don't know if hippocampal sparing is available in some and not others. But talking, what is the risk? What percentages are we talking about? What are they expecting? What is the likelihood of something showing up given your particular scenario? If you didn't get radiation, what would they anticipate? There's no way of being perfect on that, but we can speculate as to saying highly likely, less likely type scenarios.
And sorry, I didn't mean to get caught up on PCI, but it does come up a lot where patients feel like they're sort of forced into a decision without really understanding what that decision is being made for. So thank you for that. Oh. How is it determined, and is this also a shared decision conversation, or how do you determine whether somebody gets chemo, radiation, chemo IO? Like how do you decide what that therapy looks like?